All right, so we are going to talk about our case comparison. My name is Hannah.
I'm Kendall.
I'm Megan.
I'm Lucia.
All right, so a little bit about what we're going to talk about. We're going to introduce our clients and talk to you about our treatment plan that we chose for them and the level of evidence that supports each treatment plan. We're also going to talk about the models of practices that we use. So we had just a model of practice, and then we had a complementary model that we chose to use, and how that model informed the search of evidence to support our treatment plan.
So I'm going to start by introducing my client's ethnicity, religion, socioeconomic status, geographic location, etc. And so Melinda Wells is a 57-year-old Caucasian female from a rural area in Kentucky. She's a mother of 2 adult daughters and a grandmother of 3 who all live nearby, and she's married. She receives significant support from her family members and friends due to the close nature of their rural community. Additionally, Melinda's husband, he draws a retirement pension to assist the couple. Otherwise, they draw Medicaid to fund her medical expenses. Melinda was diagnosed with stage 2 ER hormone-positive breast cancer that was found during a routine medical exam. She received chemotherapy to reduce the size of the tumor and a lumpectomy and axillary node dissection. Once she recovered from surgery, she received daily radiation for 7 weeks, and she drove 25 miles each way to receive that treatment. And then 6 months after surgery, Melinda began experiencing some stiffness and fullness in her left arm and was diagnosed with breast cancer-related lymphedema. So she's now driving 25 miles to receive skilled OT services, and her primary goal is to return to work as a cashier.
My client is pretty similar in age. His name is Adam. He's 56 years old, a Caucasian male from a suburban area. He is of Hispanic ethnicity, and he identifies as Catholic. He has 2 sons. One is away at college, and another is a junior in high school. He's married to his wife, Janine, for 31 years. His wife works as a full-time chief financial officer for a chain of retail stores. Adam is a successful executive for a technology firm. He is a part of the middle to high socioeconomic status. He was diagnosed with a moderate myocardial infarction and coronary artery disease, and he was admitted to the coronary care unit. His goal is to return home and then go back to work. He was also diagnosed with high cholesterol and tendonitis of the elbow, and he has his wife and sons as social supports at home.
So my client is also in his 50s, and similar to Kendall, he is 51 years old and he's Caucasian from Eastern Kentucky. He identifies as Lutheran, and he works as a house painter and is a working class. He is married and has 2 teenager children with his wife. He was previously fully independent with all his daily activity. He first began notice his has muscle weakness in his right upper extremity and experienced stiffness in his hand and muscle and twitching in his bicep. He was diagnosed with ALS, and within a month of his diagnosis, including his head and neck and all his extremity being affected by his disease. So he's currently wheelchair confined. So my client has slurred speech and use smartphone to communicate with his family and friends by texting and typing, and he has reduced the ability to swallow, and it's on a self-diet. So my client social support, including his extended family member lives no more than an hour away, and his wife is his primary caretaker, and he has his 2 children are old enough to be able to help with house chore, and his church and community soccer league, he used to be a coach, has started a fundraiser to buy a power wheelchair for the client. So the primary goal, they're actually seeking a long-term care facility for him. So that's really different for the previous 2 cases.
So my client's name is David, and David is a 29-year-old newly married white male, and he lives in an urban area. So he is an employed carpenter from North Carolina, Raleigh, North Carolina specifically. He's worked for a carpenter for a local company for over 7 years. His wife is a full-time travel agent, and David identifies his religion as agnostic. David and his wife live on a second floor of a 2-story flat that David and his sister own, and his sister and her family occupy the first level. David led an active lifestyle prior to his injury. He actually fell off the roof while making a repair. And from his fall, he suffered a right commutative fracture with a right distal radius fracture. David was an able, full-body individual before his injury, and his really only social support he has is his wife.
Okay, so now we're going to talk about our treatment plans chosen for our clients, as well as the level of evidence to support our treatment plans. So for Melinda Wells, the treatment plan chosen focuses on vocational rehabilitation to help her return to her valued occupation working as a cashier. This is significantly influenced by her demographics. First, returning to work for the client was essential because of her low socioeconomic status. Currently, the retirement pension that her husband receives is the only source of income for her family. Additionally, the client's geographic location and social support highly influence the choice of treatment. Her community has a very close-knit nature, and so this makes the treatment feasible for her. The treatment intervention will begin by employing a worker role inventory, and this is just an occupation-based semi-structured interview that kind of analyzes the environmental and psychosocial barriers that contribute to workplace performance. So after employing the assessment, the OT will talk with the store manager and kind of find a time that the OT and the client can come in to do an intervention. This will immerse the client in the most naturalistic environment and will make the intervention more functional for her. So the treatment will begin by education on ways to utilize work simplification and energy conservation techniques to reduce fatigue while working. The client will then be asked to complete a number of tasks around the store to ensure that she's understanding those techniques. Additionally, environmental adaptations will be made, and this could include just adding a chair behind the cash register. And the OT will end the intervention session by distributing a handout to the client regarding an online breast cancer support group, and she'll provide the client with some tasks to further practice energy conservation and work simplification at home. So this intervention is strongly supported by evidence, and often breast cancer treatment related to the worker role is pretty prevalent. So one of the studies that I found by Deseron, Crutzen, Gauderis, Huth, and Reisch explored the return to work interventions for individuals recovering from breast cancer. And these researchers explained that successful interventions often utilize baseline job and client analysis following work hardening and environmental adaptations. This was utilized in the intervention by using the most naturalistic environment to allow the client to problem solve tasks, and by making reasonable accommodations to the environment to support her functional performance. Deseron also found that utilizing these specific interventions demonstrated increased satisfaction in the process of returning to work for individuals with breast cancer. The participants in the study that did not return to work started incorporating work hardening and environmental adaptations once they could return to that worker role, even if it wasn't immediately. So Barsovic et al. Employed a study that explored the effectiveness of utilizing energy conservation and work simplification techniques to reduce fatigue for clients recovering from breast cancer. And the researchers found that utilizing these techniques minimizes fatigue associated with workplace demands. Stephen et al. Also found that online support groups were beneficial in helping women in rural areas recover from their breast cancer diagnosis by supporting and empowering the women by talking to other communities of women. And so overall, the evidence significantly supports the intervention that I chose to utilize for my client.
Overall, my treatment plan also talks about return to work, but from more of an acute standpoint. So because Adam is in a coronary care unit, the intervention focused on dressing. The client's goal is to dress independently so that he could return to work. It reflects most of his demographics because Adam wants to return to work to maintain his socioeconomic status, and he has enough money to pay for supports and adaptive equipment at home. And his wife and sons can visit him because they do live in a suburban area, and they can also attend future therapy sessions. He also has access to the medical services that he needs. So in terms of the evidence for my treatment plan, according to Gerath, Crawford, Barnes, and Hardin, breathing techniques such as deep breathing can be used to reduce stress. And that was a level 4 evidence study. It was a case study. And then the next study was Weist, Mogish, and Mathiewicz, who said one-on-one education about energy conservation is an effective intervention for reducing fatigue and chronic disease. This was level 3 evidence, and it was an observational study. And then Janu McAvey said that using dressing as exercise, teaching breathing techniques, and teaching energy conservation improved outcomes such as heart labor, cardiac output, and exercise capacity. This was a level 4 case study. And then Alsaleh, Wendell, and Blake said using behavioral interventions are effective in increasing physical activity, which is important for those with cardiovascular disease. And this was a randomized control trial, level 1. So overall, my treatment plan was to educate on breathing techniques and engage in dressing using energy conservation, and then to use behavioral change strategies such as setting reminders to exercise.
Okay, so for my treatment plan for my client is self-feeding, and he's highly motivated to participate in this activity because he wants to be independent and has a strong desire to engage in family dinner. And so during the therapy section, my client will perform self-feeding, incorporating meditation, training for mindful breathing and eating, and he will learn to use adapted equipment to practice self-feeding. And I will end the section by teaching breathing exercise to help the client manage his fatigue. So the study has shown that the researcher stressed how crucial it is to have an OT with experience in ALS for guidance in choosing the most suitable device in order to avoid unnecessary expense and equipment that is not likely to help the patient, and the goal is to maintain his independence for as long as possible. So there's a variety of adaptive equipment available to support people with ALS. And that's the reason why that, because my client has muscle weakness in his upper extremity as well as impaired grasp, using adaptive equipment will provide physical support to for him to engage in self-feeding, and therefore to increasing his experience and his occupation performance in self-feeding. And the reason why that we're doing meditation training, because study has revealed that is a useful tool for increasing well-being and quality of life of a client with ALS, as you can help clients manage their feeling and their response to their illness. And research found that decreasing anxiety and depression, both which are common in people with ALS, and practicing meditation can help the client to focus on what they are able to do and not on what they're unable to do. And so because my client has difficulty coordinating with his breathing and swallowing when he's eating, so it's crucial for him, for my client to pay attention to his breathing and to be mindful of what to eat while engaging self-feeding. So therefore that's why I'm teaching him meditation technique. So additionally, there are tons of study and strong evidence support that breathing exercise can help with strengthening expectoration muscle, and studies have showed that the positive benefit of breathing exercise include a decreased peripheral and respiratory muscle fatigue, and increasing and also promote quality of life in people with ALS. And because fatigue is one of the barriers that affect my client's ability to engage in family dinners, therefore that I will provide breathing exercise education to help him managing his fatigue. And also you will help him recognize his limits and take breaks throughout the day by incorporating breathing exercise, especially when he's experiencing shortness of breath or when he has trouble breathing.
So mine is very similar to Kendall and Megan's that focus on kind of environmental adaptations and then energy conservation as well. So David, my client's current goal is that he will attend a sporting event with supervision by the end of November. As I mentioned earlier, David currently has limited mobility due to his fractures. So it leaves him not to be able to attend these events. And he did like to go to these and led an active lifestyle before his injury and regularly attended them. So his current weight bearing status is weight bearing is tolerated. And he did have and still has an external fixator, which limits his functional use of his leg, you know, getting in and out of a vehicle, walking, sitting at a stadium. And then also his distal radius fracture limits his ability to use his hands, which could limit his ability to use adaptive equipment such as a cane, a walker, or even a wheelchair. So getting around at a sporting event, as we all know, it requires a lot of physical exertion and effort. And, you know, David currently does not have that due to his injuries. So an intervention I thought that I could provide that would be similar to going to a sporting event could be walking his dog in a park and getting some outdoor community mobility. And so a study done in 2011 by Gutcher, Frick, and Buckchecker found that they did a study on these outdoor recreation areas and found that, you know, walking and jogging and cycling, they do affect an individual's ability to find like outdoor recreation areas. They also found in this study, it was interesting that people who have a dog, like dog ownerships, have a greater influence on more frequent visits to an outdoor recreation area. Another intervention that I thought that I could apply to this to make this similar for David, going to a sporting event or getting him ready to go to a sporting event, was using occupation goal by using gaming systems. So a study done by Taylor, McCormick, Shaw, Empson, and Griffin in 2011 found that activity promoting gaming systems in exercise and rehabilitation. This study evaluated the Nintendo Wii and how it relates to energy expenditure while playing and how it kind of relates to the game or the actual activity. So one aspect of this study kind of focuses on rehabilitation and activity promoting gaming systems. And this study also found that, you know, using the gaming system promotes balance training, upper limb motor functions, and coordination. So I thought that study would be very supportive of my goal for getting him to a sporting event, whether it was him playing, you know, Wii bowling or even the baseball sport on Wii. It'd be very similar to him going to a sporting event. He's getting that physical exertion. So on to the next one.
So now we'll talk about the organizing models of practice as well as the complementary models of practice that we chose for our clients and how these models informed our search for evidence to support our treatment. So for Melinda, the occupation-based model that I thought would be best suited for her was MOHO. And as we all know, MOHO considers the human to be a dynamic system that's continually changing to meet the demands. So the primary components of the model are volition, habituation, and performance capacity. So for the client, volition would be a primary consideration because returning to work for her is very important and she's very committed to her job. Additionally, the client's role as a cashier and the habits surrounding the occupation are significantly important. And this would be important to consider while helping the client achieve her goals. When it comes to performance capacity, this is important because addressing the client's mental and physical capabilities is crucial. So it would be essential to address edema reduction, strength, range of motion, etc., and also to address fatigue. And so in addition to MOHO, I used two complementary models, and these included the rehabilitative and biomechanical models. So the rehabilitative model was chosen to just provide an additional layer by incorporating strategies and techniques to modify and adapt the workplace, whether that be energy conservation, environmental modification, or use of assistive devices. For the biomechanical model, this was chosen to address kind of some underlying physical limitations, including edema, strength, range of motion, etc. So these models significantly informed the way that I searched for my evidence. because it was important that I used a volition, habituation, and performance capacity lens when searching for research. So also through the research, I discovered that MOHO is the most common model utilized in work rehabilitation for individuals recovering from breast cancer. And usually this is because MOHO provides tools and instruments that concern the return to work. The rehabilitative and biomechanical models also shaped how I collected evidence, because through the rehabilitative model, I started looking at environmental modifications and work simplification. And with the biomechanical model, I could start kind of looking at the underlying physical impairments that the client had in order to kind of connect the holistic view of the client.
I used an occupation-based model that was different from Kindle's. I used the Person Environment Occupational Performance Model, or the PEOP model. So they state that the PEOP model first considers the client's roles, occupations, and goals. So the client's primary concern was to return to work. And through this model, I can address different factors like physiology, psychology, emotions, and spirituality. So physiologically, the client has decreased endurance, so I can address that through this model. And then I can also address psychology and emotions by incorporating interventions that address stress. And the client could also be depressed, so I could address that through this model. According to Wong and Fisher, the PEOP model also examines the environment in terms of whether it facilitates or inhibits the person. So my client lives in a 2-story home, and that can limit his access to the upstairs rooms. So through this, I can evaluate and treat in a way that can provide the individual access to his home. I also use the biomechanical frame of reference as a complementary model. So in addition to addressing the environment, I can also look at the specific impairments. So using this model, I can address things like endurance, strength, and heart function. So the biomechanical model focuses more on the specific impairments, and then the PEOP model addresses more of the demographic type of things. So these models definitely informed how I searched for my evidence. And using the PEOP model, I focus more on environment, so using adaptive technology and then modifying the environment to make it easier for my client to move around with decreased endurance. And using the biomechanical frame of reference, I looked specifically at how to improve the impairments, such as endurance and strength. So that's kind of where the fatigue management came in.
So mine is very similar to Megan's and Kendall's. I'm going to talk very briefly about it since they've covered both of these models. So David, it was more for his PEOP, it was more looking at him and what barriers, his environment was causing for him and his injuries. So the therapist kind of took these into consideration when creating the intervention plan. Also used the biomechanical frame of reference because it specifically deals with his injuries, their fractures, it deals with the joints, the range of motion of the joints. So the therapist took all of this in consideration when developing his intervention plan.
Went off. Okay, so for my client, I choose the CMOPE, and the reason for that, it's very different from everyone's clients because he was diagnosed with a progressive degenerative disease, so he's not going to recover for his disease. So for this reason that he and so that's the reason that why I choose this model, because it's client centered and as the main essence of the person. So spirituality is an essential component to understand the client beyond his occupational participation and to find what defines him as a person, including client factor and value. And so it goes beyond occupational performance to include the concept of occupational engagement. So, and that's so I thought it was the most appropriate to support him to identify and engage in a meaningful occupation in his environment, which will increase his quality of life. So the second model I choose, which was I believe similar to, it's the same as Megan, is PEOP, and the reason for that is because this treatment is planned using a top-down approach, starting with collaboration with the client in discussion of his desired occupation. So by observing him participating in environments such as family dinner and identify interesting factor that supports the engagement in his desired occupation, and also the factor that may impair his ability to complete his occupation, that helps to learn whether he has support from his family and his community, and to consider how adaptive equipment may increase in his engagement in meaningful activity. And so in order to determine the best intervention for my client, it was essential to look within the client's personal and environmental context in order to address the client's personal performance, ability, limitation, and the environmental performance enabler and barrier that are necessary to the client's occupational performance. And yep, that's it.
So kind of wrapping things up, there are a lot of comparisons as well as contrasting things between our clients. And so mine and Megan's, we focused on return to work, but our focus was very different as far as what we were working on in that return to work. While Hannah addressed leisure and Lucia addressed more ADL participation. When it came to our treatments, me and Hannah and Lucia all looked at environmental modification. And when it came to the models, me and Megan and Hannah all looked at PEOP, but had some diversity as far as me covering MOHO and Lucia covering CMOP-E. And then the last thing was the biomechanical model. 3 of us employed that to look at the underlying impairments because we know how important that can also be an intervention. So in all, there are a lot of comparisons and contrast between our clients, which makes it important to kind of look at when creating OT interventions.
Thanks for watching.